This is going to be topic 53, Obstetrics, Normal Pregnancy.
This is going to be chapter 35, Normal Pregnancy. Key concepts. Upon completion of this chapter, you'll understand the normal changes of pregnancy that can lead to medical consequences or exacerbate pre-existing conditions. The 3 time frames called trimesters pregnancy is divided into, each lasting approximately 13 weeks. The differing health problems that may present during each trimester and the differing effects on the mother and the fetus. Chief concerns. Consideration for pregnant patients: is it early or late in their pregnancy? Are they healthy or do they have long medical histories? Do they have any pre-existing medical conditions? Might the patient be hypoglycemic? Are they dehydrated? Is venous stasis have anything to do with this? Do they have a DVT? Things like this. In the first trimester, the first weeks of pregnancy, there's lots of complications and side effects that just generally normally occur during this time frame. Amenorrhea, or the absence of menstruation, and there are many causes of this, including pregnancy. Awareness of the pregnancy, if they are having any abdominal cramping or spotting, nausea or vomiting, which is also common in the first trimester. Placental development, and this is where checkups with their obstetrician are important. Circulation, both maternal and fetal circulation. And then main functions. Is the metabolism correct? Transfer of nutrients and waste okay? How's their endocrine functions? All are concerns within the first trimester. In the second trimester, and this is the 4th through the 6th month, they include the feeling of energized, and the reason that they get energized is because during the first trimester they have morning sickness and fatigue, and this starts to subside, so they get a little bit more energized. Weight gain and uterine enlargement also occurs during this time frame. Braxton Hicks contractions, non-rhythmic, sporadic, generally not painful. And this could also be a result of dehydration. And the quickening, time frame during which a woman will first start to appreciate fetal movement. During the quickening, they'll start to realize that there's something growing inside. First-time mothers may feel the quickening as early as 20 weeks. Third trimester concerns, they include fetal growth. And when the fetus is developing, they lay down subcutaneous fat in this area, uterus enlargement, and this may cause shortness of breath. The reason this occurs is because it pushes on the diaphragm as the fetus is growing. Supine hypotension syndrome commonly occurs when a pregnant woman lies supine in position, and the reason being is the weight of the fetus pushes up against the vena cava, which reduces the amount of preload. The weight of the uterus and its contents compress the inferior vena cava, decreasing venous return to the heart. Psychological adaptations, and this would be of unplanned pregnancy, may cause stress on the patient. Special cases, abdominal pain in pregnancy. Often women that are pregnant have common pain in their abdomen, and this is because of round ligament pain. It can be caused from stretching of ligaments and the movement of abdominal contents. We're going to look next at table 35.1, extrauterine causes of abdominal pain. Variations, same that we can get with abdominal pain in a normal patient. Appendicitis, there could be a bowel perforation, gastroenteritis, diabetic ketoacidosis can also cause this, kidney stones, ovarian cyst rupture, pancreatitis, peptic ulcer disease, pneumonia, a pulmonary embolism. We should be looking for on each one of these determining and differential diagnosis, or they could be in sickle cell crisis, and history would be important in this. Urinary tract infections can also lead to abdominal pain or cystitis. Anatomical and psychological changes of normal pregnancy, and they include multiple areas here, so we're going to talk about each one just a little bit. Cardiovascular, blood volume increases, increased plasma volume, approximately 50% overall volume. The anemia of pregnancy is an imbalance of the plasma volume to hematocrit, so it essentially dilutes out the blood. Clotting factors rise. There's a decrease in arterial blood pressure. Hypotension naturally occurs and can result in orthostatic changes. So when they stand up really quick, they can become have a decreased level of consciousness because of loss of blood supply. This can occur secondary to supine hypotension syndrome, which would be the inferior vena cava being occluded. Maternal heart rate normally increases during this time frame. Pulmonary section. Tidal volume increases. Total lung capacity is reduced. Anterior, posterior, and transverse diameters of the rib cage increase, so the rib cage gets a little larger. Minute volume increases. Asthma in pregnancies can complicate the care of a pregnant woman. This would be secondary to hormonal changes and or medications. Tocolysis, we use actually beta agonists to slow labor. Use corticosteroids with more caution as well because of you can get an increase in glucose levels. Gestational diabetes. Gastrointestinal. Progesterone slows gastrointestinal motility, increased reabsorption of the water. Prolonged gastric emptying along with the relaxation of the gastroesophageal sphincter contributes to heartburn and reflux. Vomiting and morning sickness. Hyperemesis gravidum, which is excessive vomiting of the pregnant woman. Renal, the kidneys increase their glomerular filtration rate and start moving things faster. Dilation of the ureters. Urinary bladder is typically displaced upwards and is flattened against the pubis bone during this time frame as well. Lots of changes. History. Focus on the mother's health. Standard sample format. History of the pregnancy. Conditions of concern, especially in special patients where if they're asthmatics, they're diabetics, they have history of epilepsy. Present pregnancy history considerations. When was their last menstrual period? Their pregnancy symptoms, any symptoms that they might be having today, and present pregnancy history. Menstrual, obstetric, and gynecological history. Menstrual history helps in calculating the estimated date of delivery. We can calculate the estimated date of confinement or the delivery date by using Nagel's rule. And Nagel's rule is the date of their last menstrual period plus 7 days minus 3 months. So, example, if they were last menstrual period was June 1st, plus 7 days would be June 8th. June 1st plus 7 would be June 8th minus 3 months, which would be March 8th. Obstetric history. Note their number of pregnancies, deliveries, and miscarriages. We do this by something called GPA determination, or gravida, para, and abortus. Do this here a little bit. Gravida is how many times that they've been pregnant. Para would be how many living children they have. And abortus would be whether this was spontaneous or therapeutic as far as the abortion goes. An example of this, let's say that they've been pregnant twice, they have 1 living child and 0 abortions. So this would be the female's second pregnancy and has 1 living child. So they're G2 para 1 A0 when giving history and reporting. And as far as the gravida goes, there's several terms with this. Nulligravida, which is a woman who has never been pregnant. A primigravida, a woman who is pregnant for the first time. And then a multigravida, a woman who has been repeatedly pregnant. TPAL method is also in the history here. And this would help us determine very quickly our GPA score, if you will, or GPA determination. Term deliveries the mother has had, preterm births the mother has had, abortions to where they were spontaneous or therapeutic, and the amount of living infants. Whenever you're documenting, please put it in GPA format. Obesity and pregnancy. Pregnancy, maternal obesity increases the risk of PIH or pregnancy-induced hypertension, venous thromboembolism, and this will lead to pulmonary embolism, and gestational diabetes. Substance abuse and exposure, tobacco, alcohol, and recreational drug use can adversely affect pregnancy and perinatal morbidity and mortality. Infants both with fetal alcohol syndrome have permanent birth defects. Cocaine can induce profound hypertension, leading to placental insufficiency, and secondarily, spontaneous abortion and placental abruption. Exposure to substances with potential for tetragenicity. A tetragen is any substance or agent or environmental factor that has an adverse effect on the fetus. And then family history. Family history of a disorder places a woman at an increased risk for developing that disorder. Examination. Perform a head-to-toe exam, semi-reclined position, and this is so that the weight of uterus is off the diaphragm. If we lie them flat, sometimes we'll get some shortness of breath, or if we place them on their right side, we'll get venous stasis, or from a decrease in preload on the inferior vena cava side. Vital signs, focus on the blood pressure. They can also have something called prurigo. Hormonal changes during pregnancy sometimes make pruritus, which are soft pupillary lesions found on the hands and feet. Cardiothoracic examination. The breasts may have increased their sensitivity due to hormonal changes. Heart murmurs can develop as well, secondary to an increased volume of blood. Examination of the limbs may reveal edema. If the person is experiencing a new onset of heart murmur, they'll, however, report it, take them to the appropriate facility, and get them a checkup. Most of the time, this is a 12 to 24 hour examination. They may even put them on a Holter monitor to see if any kind of adverse EKGs pop up. Examination of the pregnant abdomen. Considerations. Look, listen, and feel approach. Look for bruising, scarring, fetal movement, fetal heart sounds. Estimate the fundal weight. Leopold's 4 maneuver. Palpate the upper portion of the abdomen. Place your hands bilaterally at the mid-abdomen, using the left hand to stabilize. Push against the fetus with the right hand against the left hand. Place one hand above the sympus pubis. Try to cup the infant's head with the other hand. Paramedics should turn, face the feet, and palpate the lower abdomen bilaterally. And this just gives you a guesstimate on how big the actual fetus is. This is figure 35.3, points of auscultation of the fetal heart sounds. The red dots here indicate where the best place to auscultate the fetal heart sounds would be, depending upon the fetal position. If there's any way you can keep the fetal heart tone monitor to yourself and find the fetal heart tones, that would probably be better. A lot of people anticipate the heart tones, feel that they need to hear it, and they get kind of an increase in anxiety if you can't find it. And sometimes this can be like looking for a needle in a haystack. So until you make the assessment and you find the location, sometimes it's better to where you can only hear the fetal heart tones. Remember, there's going to be 2 sets of pulses in here, one from the fetus and then one from the mother. Assessment. Differentiation between common discomforts and potential complications can be difficult. Sometimes the same symptoms we can find in a person that's having complications are the same symptoms of normal pregnancy. Assessment includes determination of pregnant-related issues and any kind of treatment implications on the pregnancy and the fetus that might occur. Be careful on your medications, on the determination and the classifications of them for the pregnant female. If any questions, call and clear any potential treatments with appropriate medical control. To treat the mother is to treat the fetus. The mother's welfare is the most important for fetal survival. Concerns related to the normal pregnancy complaint. Treatment involves generally just supportive care. Upon evaluation, seizures can occur for many reasons: eclampsia, hypoglycemia, hypoxia, or head injury. Keep an open mind and use differential diagnosis to guide your path. Eclampsia generally comes from a history as well, typically preceded by preeclampsia and or pregnancy-induced hypertension. There are 4 phases of this: simple facial twitching, unconsciousness, and then tonic-clonic phases to where they resemble seizures. On the disposition considerations, transport on the left lateral position. The aorta can take a whole lot more pressure than the vena cava can. Provide oxygen. Trauma center may be indicated. Transport high risk to a neonatal intensive care unit. Transport prenatal care location. Disposition. Considerations. Transport the patient in the left lateral position. Provide oxygen. Trauma center may be indicated in these patients. Transport high-risk patients to neonatal ICUs. Transport the patient, if not otherwise indicated, to where they had their prenatal care at. In conclusion, normal pregnancy is a natural process that starts with the fertilization and ends with the delivery of the baby. An understanding of this process will help the paramedic effectively care for the pregnant patient.
If you have any questions concerning this topic, feel free to contact me. My name is Roy Smith, Smith Arts, Samaritan EMS, OK.com, or 405-492-8243. Thank you.